Thank you for the opportunity to speak today. My name is Brad Wertheim. I'm an associate physician in the Division of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital, and I'm an instructor of medicine at Harvard Medical School. Today we will be discussing a challenging pulmonary case. I have no relevant conflicts of interest germane to this presentation. So today we'll review a case of a 30-year-old woman with exertional dyspnea. She last felt normal a few years ago, subsequently developed onset of exertional dyspnea. This was originally attributed to asthma and bronchitis. For a number of years, she was treated with recurrent courses of prednisone, antibiotics, and inhalers without significant clinical improvement. Symptoms progressed over time, and currently she can walk approximately 3/4 of a city block or even just one flight of stairs without having to stop to catch her breath. She has had to stop working from her job, and she was recently evaluated in a local emergency department for interval development of new lower extremity edema that was treated with furosemide. Currently, she endorses exertional lightheadedness, but no syncope or chest discomfort, and she was referred to the emergency department from clinic. Review of systems is notable for a new cough, not a long-standing issue for her, something developed over the course of about the last week or so. Review of systems was negative for heart disease, connective tissue disease, DVT, PE, or splenectomy. Past medical history was notable for a childhood diagnosis of asthma, strabismus surgery, depression, and anxiety. She was treated with budesonide and formoterol inhaler, escitalopram, furosemide that was recently started, and hydroxyzine. She had no allergies, and she endorses occasional marijuana use, but no tobacco, other drugs, or occupational, industrial, or animal exposures. She works in education, and she was adopted, so no family history regarding the biological relatives was available. On physical examination, heart rate was 82, blood pressure was 107/72, and on brief ambulation, she desaturated from 94% on room air at rest to 85%, and that was associated with a heart rate of 140 with walking. Body mass index was 40. Lungs were clear, there was no clubbing, no jugular venous distension was appreciated. Cardiac exam was notable for an absence of murmurs. A normal P2 was present. There was no RV heave or PA tap, and exam demonstrated 1+ lower extremity edema. There were no telangiectasias or stigmata of liver or chronic connective tissue diseases. The initial laboratory studies available during her first presentation included normal chemistries, normal CBC, unremarkable rheumatologic studies, negative HIV, a TSH that was mildly elevated, a free T4 of 1.1, an NT-proBNP elevated at approximately 2,700, and the rhinovirus PCR was positive in the setting of the new onset cough. Pulmonary function tests were not available. Chest X-ray indicated vague upper lung zone opacities, and a available 6-minute walk was notable for a distance of 291 meters, which is 27% predicted based on her demographics. A PE protocol chest CT was obtained, given the constellation of symptoms. It was negative for pulmonary embolism, but a number of salient findings were observed. There were multifocal ground glass opacities observed in the lung parenchyma, as visualized here. Furthermore, there was a dilation of the pulmonary artery appreciated. This is best indexed when by comparison to the aorta. So you can see here that the diameter of the pulmonary artery measures larger than the diameter of the aorta, and that's a reasonable rule of thumb suggesting PA dilation, which has an associated differential diagnosis that includes pulmonary hypertension. Furthermore, it was appreciated that even on this CT, there was evidence of enlarged right-sided cardiac structure, specifically an enlarged right atrium, an enlarged right ventricle, and it appeared that the left side of the heart was underfilled. As a result of that CT finding, a transthoracic echocardiogram was obtained. And we'll see here, this orients you to an apical four-chamber view of the heart. We see a right ventricle, a right atrium, a left ventricle, and a left atrium. And I call this here a real-world quality. As you can see that the left-sided cardiac structures are somewhat out of the plane of imaging, but there is enough available information here to be able to draw pretty important conclusions from this. So returning to the echo image on the left, we can see it's notable for the following. We have a dilated, relatively hypertrophied right ventricle. And that right ventricle essentially forms the apex of the heart, which is an abnormal finding. Normally in this view, the left ventricle is the dominant cardiac structure at the apex of the heart. Furthermore, you can see qualitative evidence of reduced RV systolic function. We can see the right atrium is markedly dilated, as seen in the chest CT. And there is interatrial and interventricular septal bowing with compromised filling of the left ventricle, leading to somewhat hyperdynamic and underfilled left heart, likely contributing to the patient's symptom of exertional lightheadedness. As a result of these findings, the patient underwent a resting right heart catheterization, given the concern for a pulmonary vascular cause of her symptoms. Resting supine hemodynamics were notable for the following: a mean right atrial pressure of 14, RV pressure systolic of 92, and an end diastolic pressure of 19, which markedly elevated and compatible with a right ventricle that is off the back of its Starling curve, so to speak. The mean pulmonary artery pressure was 59, so this patient essentially has a nearly systemic PA pressure. A pulmonary artery wedge pressure mean was 7, indicating normal left-sided filling pressures. By the indirect Fick method, a cardiac output was 3.04 liters per minute, which indexed for body mass gives a cardiac index of 1.6, which is quite low. The pulmonary vascular resistance was well over 1,400. By comparison, a normal pulmonary vascular resistance is somewhere in the 80 to 120 range for younger, healthy people like this patient. There was no oximetric evidence of left to right shunt. So these data are compatible with severe precapillary pulmonary hypertension with a reduced cardiac index. As a complement to these findings, the following additional study was performed in the cath lab. This figure here depicts what's called a selective pulmonary artery wedge angiogram. The PA catheter is floated to the wedge position, and IV contrast is injected through that catheter to opacify the pulmonary vessels, qualitatively evaluate the extent of the pulmonary capillary density. It will also give you a sense of whether there's any chronic filling defects that could be compatible with the diagnosis of chronic thromboembolic pulmonary hypertension, and it can furthermore provide evidence on the adequacy and quality of pulmonary venous return to the left heart. So I'll pause while this image loads. So what you can see here is that there's a dramatic loss of the normal capillary arbor of the pulmonary vascular bed. And this leads to what we call a pruned appearance of the pulmonary arteries. The study was also notable for an absence of any stigmata of chronic thromboembolic phenomena. Put together with her prior chest CTA, essentially removes chronic thromboembolic pulmonary hypertension from the differential diagnosis. So where do we go from here? And before we dig into the case further, I think it's important to review some anatomic and physiologic concepts about how we think about pulmonary vascular disease. The pulmonary circulation is a low pressure, low resistance, high capacitance system, which is in contrast to the systemic circulation. We think about pulmonary vessels as the following: precapillary vessels, pulmonary capillaries, and postcapillary vessels. And as a result of this low resistance, high capacitance system, the right ventricle is typically a very thin-walled structure that adapts very poorly to changes in afterload compared to the much more hypertrophied and robust left ventricle, which is made to pump against a higher afterload. I think it's important to emphasize that pulmonary hypertension is a syndrome. It's not a diagnosis. It's essentially a final common pathway of heart-lung failure in response to an insult somewhere in the pulmonary circulation or left heart. For example, diseases of the pulmonary arteries and capillaries are typically as follows. One is pulmonary arterial hypertension, a syndrome that we commonly learn about in medical school and see rarely in the clinical realm. Another condition affecting these vessels is chronic thromboembolic pulmonary hypertension, as I've alluded to previously. A rare disease, but one that nonetheless affects pulmonary capillaries, is a condition known as pulmonary capillary hemangiomatosis. And then finally, more common conditions that we see in the clinical realm, such as interstitial lung disease or COPD, affect kind of a mix of pulmonary capillaries and pulmonary arteries. There are other conditions that affect the pulmonary veins. Usually pulmonary veno-occlusive disease is the prototypic example of that. And although it affects the pulmonary veins, it's a tricky syndrome to catch and diagnose because it actually presents as a mimic of pulmonary arterial hypertension. Finally, failure of the left ventricle by virtue of heart failure with preserved ejection fraction, reduced ejection fraction, valvular heart disease, and so forth can present with pulmonary hypertension that is predominantly caused by a cardiac rather than a pulmonary vascular phenomenon. So more terminology is in order. Pulmonary hypertension is defined by a mean pulmonary artery pressure greater than 20 millimeters of mercury at the time of resting supine right heart catheterization. That's a new definition as of 2018. Pulmonary arterial hypertension, on the other hand, is a specific and very rare cause of pulmonary hypertension defined by elevated pulmonary vascular resistance and also a normal pulmonary artery wedge pressure. I'll use the definitions pH and PAH to refer to these respective terms for the remainder of the presentation. So both pH and PAH lead to right heart failure and can frankly present with a somewhat similar clinical syndrome, but management is actually very different, and it's a very important distinction to identify which bin your patient falls into. So what are the presenting signs and symptoms and data that can point to a diagnosis of pulmonary hypertension? So most commonly, patients present with typically at first exertional dyspnea and eventually hypoxemia that can appear out of proportion to other comorbidities. This is often recognized at the time of ambulatory oximetry, which is a very cheap, simple, easy diagnostic test that can be performed by anyone in clinic. and it is a useful screening tool when trying to risk assess these symptoms. Patients can also present with an RV failure syndrome, which also has a fairly extensive differential diagnosis. This syndrome of RV failure of any cause, but specifically a pulmonary vascular form of RV failure, tends to present with the following. You can appreciate an RV heave or a PA tap on physical examination. That can also occur in the setting of a loud P2 component of the second heart sound, right-sided S3 or S4, congestive symptoms that may take the form of lower extremity edema, ascites, fatigue, early satiety, although not all these patients will go on to develop frank congestion. That's why a pretty high index of suspicion is needed. The symptoms that really keep me up at night with respect to pulmonary vascular disease are those symptoms associated with the underfilled left ventricle, such as presyncope or syncope. Typically, those symptoms are concerning if they occur in the context of exertion. And then finally, angina can occur in the setting of chronic subendocardial RV ischemia in the setting of very severe disease, and that's also a high-risk finding. With respect to echocardiogram, pulmonary hypertension may present in the setting of an enlarged right atrium or right ventricle. There may be interatrial and or interventricular septal flattening. In the case of someone with pulmonary hypertension caused by left heart failure, you also need to pay attention to the left atrial, left ventricle size. The inferior vena cava size in echo can be another soft indicator of right-sided filling pressures. I do mention RVSP here. However, although many use the RVSP as kind of an initial item to build their pretest probability of pulmonary vascular disease, I would actually encourage you to look at some of these other aspects of cardiac morphology, which tend to be perhaps a little bit more robust with respect to the technical quality of the study. Very subtle changes in how the echo is performed can lead to very large changes in right ventricular systolic pressure, which is one of the reasons why right heart catheterization is really the cornerstone of diagnosis for these patients. And there are many, many, many other findings on echocardiogram that can be useful in risk assessing these symptoms. Pulmonary function tests can be helpful. Perhaps the most important take-home point of PFTs is that a reduced diffusion capacity of the lung for carbon monoxide can signify pulmonary vascular disease. Oftentimes that can be what we would say would be out of proportion to the other clinical findings. For example, if you have a patient with essentially normal spirometry, normal lung volumes, but the DLCO comes back at 20% predicted, there's obviously a significant issue there that needs to be worked out, and that could be concerning for pulmonary vascular disease. As we saw, the chest CT actually can provide quite a useful amount of information on cardiac and pulmonary vascular structures, as well as evaluation of parenchymal lung disease. So we look to the size of the pulmonary artery, the size of the right and left sided filling structure, or right and left sided cardiac structures. One clinical sign that I find can be somewhat useful is that for a pulmonary embolism protocol study, the presence of contrast material refluxing from the right heart into the inferior vena cava and hepatic veins can, but not always, be associated with elevated right-sided filling pressures. Finally, there are some laboratory values that can also influence your pretest probability for pulmonary vascular disease, and those include NT-proBNP, creatinine associated with congestive forms of renal failure. An elevated red cell distribution has been associated with pulmonary vascular conditions. Finally, in the setting of frank heart failure, you can see hyponatremia. And also, it's well described that patients with pulmonary arterial hypertension in particular are at greater risk for glucose intolerance compared to normal controls. So how do we go from a right heart catheterization result to narrowing the differential diagnosis for the cause of the patient's pulmonary hypertension? As I mentioned earlier, this really hinges on the resting supine right heart catheterization. And we can bin patients into three rough hemodynamic physiologic profiles that can be helpful. Pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, and those patients with both. So beginning with pre-capillary pulmonary hypertension, that's defined by a pulmonary vascular resistance of greater than or equal to 3 Wood units in the setting of a normal pulmonary artery wedge pressure. This form of pulmonary vascular disease is associated with vascular remodeling of the small arterioles, proliferation of smooth muscle cells, deposition of fibrosis, and a variety of other biological abnormalities that lead to an impedance in blood flow through the lung and an increase in RV afterload. Prototypically, pre-capillary pH is characterized by, can be seen in the following forms of pulmonary hypertension. One is pulmonary arterial hypertension. That's the classic patient who falls into this category. And that is the category that the patient in our clinical case would fall into. This is also defined by the World Health Organization as Group 1 pulmonary hypertension. However, there are other forms of pulmonary hypertension that can present with a precapillary pattern. pH in the setting of chronic lung diseases or chronic hypoxia, that is WHO Group 3. Chronic thromboembolic pulmonary hypertension, which is WHO Group 4. And then finally, pulmonary hypertension arising in the setting of multifactorial or unknown mechanisms falls into Group 5, can also be precapillary in physiology. By contrast, postcapillary pulmonary hypertension is defined by a pulmonary vascular resistance of less than 3 Wood units. And as you may recall, you can see that the pulmonary vascular resistance in Wood units is defined below as the difference between the mean pulmonary artery pressure minus the pulmonary artery wedge pressure divided by the cardiac output. And patients with postcapillary pH can be thought of as having perhaps what we call a passive congestive pattern. Basically, left-sided filling pressures are high. Over time, those pressures are transmitted to the pulmonary vascular bed and eventually the right heart. And these folks with LV failure of potentially a variety of different mechanisms fall into the WHO Group 2 category of pH. Finally, those individuals with both elevated pulmonary vascular resistance and elevated wedge pressure define the combined pre- and post-capillary group, a very challenging group of patients to treat and care for, as the physiology is defined by both vascular remodeling and congestion. And patients with WHO Group 2, that is LV failure-related pH, can develop this over time, as can patients with WHO Group 5. And I think it's important to point out that the vast majority of patients you will see will not have pulmonary arterial hypertension. The vast majority of patients with pulmonary hypertension will have it arising in the setting of a chronic lung disease such as COPD, or post-capillary pulmonary hypertension from their LV failure. And it's not uncommon to see patients with both Group 2 and Group 3 pulmonary hypertension physiology. And again, very challenging patient population to treat. So how do we treat? So I'm going to focus on pulmonary arterial hypertension treatment because that's what's germane to the case at hand today. So we think about treatment strategy hinging on a couple clinical factors. Probably most important to the literature and to our approved therapies for PAH is the functional class of the patient, defined by essentially the New York Heart Association class, which is very similar to the World Health Organization functional class for pulmonary hypertension. So beginning at folks with functional class 2, and on a spectrum of, yes, they have pH, but perhaps they have lower risk hemodynamics, we begin with what is called upfront combination therapy. And that entails treatment with a phosphodiesterase type 5 inhibitor. Those are drugs like sildenafil, tadalafil. plus an endothelin receptor antagonist such as ambrisentan, macitentan, bosentan. That combination, in particular, ambrisentan plus tadalafil, compared to a strategy of pooled monotherapy, that is, you either get PDE5 inhibitor or an ERA up front, decreases a combined endpoint of death, PAH hospitalization, disease progression, and poor clinical response by approximately half. This was shown in the landmark ambition study in the New England Journal from 2015, and has really gone on to define the standard of care for those patients with essentially functional, with kind of lower risk functional class and lower risk hemodynamics on presentation. Conversely, on the other hand, take the sickest patients. These are functional class 4 patients, debilitating resting symptoms, getting short of breath, eating, dressing, having a hard time even walking out of the room. Those folks carry a higher risk hemodynamic profile, and really continuous IV prostanoid is really our cornerstone therapy there. Those are therapies like IV treprostinil, IV epoprostenol, and also those patients should be evaluated for lung transplant. And now, what to do with the patients in between? And this is actually 70% of incident PAH in the ambition study actually presented with functional class 3 symptoms. And this really reflects late diagnosis and sometimes late referral. And as you might imagine, the patients with functional class 3 fall somewhere in between on this treatment spectrum. Some of those individuals will get upfront combination therapy. Some of those individuals will get started on IV therapy. And I should also mention that at least in clinical practice now, the majority of pulmonary hypertension clinicians will also continue upfront combination therapy in those patients that we start continuous IV prostanoid on, unless there's a contraindication, poor clinical response, or other good reason to start it. Like other conditions such as malignancy, HIV, the emerging opinion in PAH is that probably upfront strategy with multiple drugs leads to probably a better long-term outcome than sequential therapy, although whether that applies to triple PDE5 inhibition plus endothelin plus prostanoid is still being sorted out. So with this in mind, let's go back to our patient and what did we do to treat her? So she was admitted to the hospital and started on upfront combination therapy with IV treprostinil first, followed by addition of tadalafil and ambrisentan over a period of a couple of weeks. We tend to start a low dose and then up titrate once patients on multiple therapies. In addition, no discussion about PAH therapy is complete without a discussion of background therapies. These are what are all the other things that you're going to do to treat this patient. And I think it's really actually important to emphasize that in addition to pulmonary vasodilators, really the cornerstone of aggressive PAH therapy is meticulous general internal medicine. You need to be mindful of every organ system, not just the lung or the heart. And in this patient, it included supplemental oxygen as she demonstrated exertional and nocturnal desaturation, exercise and pulmonary rehabilitation. In this patient who had an elevated BMI, weight loss is an important part of the therapeutic strategy. Decongestion with diuretics, in this case furosemide. Her thyroid function studies were slightly abnormal, and she was referred for thyroid evaluation and optimization. Patient education is really critical. Heart failure diet education, you really have to teach these patients to become their own disease manager. And then lung transplant referral should be considered typically at the time of referral for IV prostacyclin therapy, although that's an individualized decision based on patient factors and the transplant center factors. So in follow-up, the patient who presented with, we'll say, a functional class 3, class 4 diagnosis is now a solid class 2 after approximately 6 months of therapy. She can now walk 1 mile, and this is a dramatic improvement from someone who could barely walk 3/4 of a city block and just barely make it up a flight of stairs, and has gone back to hiking. NT-proBNP on recheck is 108, down from 2,700. And I should also mention that we would normally follow up an echocardiogram, 6-minute walk, and in this particular patient, given the ground glass, a chest CT before the 6-month mark of follow-up. But in the setting of the COVID-19 crisis, those studies were delayed given the risk-benefit relative to bringing her in contact with the healthcare system, although those will be obtained shortly. I should mention, and one of the reasons why I like this case is that the ground glass opacities that we saw on the presenting chest CT are almost certainly a red herring. They're likely related to the concomitant rhinovirus infection that we demonstrated by PCR. As you recall, she had that cough that was new about a week before she presented, and has subsequently resolved. Her physical exam doesn't demonstrate crackles. I think most likely those have normalized, but typically multifocal ground glass is not a prototypical presentation of PAH, and the presence of ground glass in the setting of someone with this syndrome should prompt you to think about other etiologies or to reconsider the potential diagnosis of PAH in the setting of those abnormalities. So likely unrelated, and I'm almost certain they will have resolved at the time of repeat scan. So some clinical pearls to take home after our discussion today. Many PAH patients are inappropriately treated with asthma medications prior to a PAH diagnosis. On average, most patients have symptoms for approximately 3 years prior to their ultimate diagnosis of PAH. Ambulatory oximetry can be very informative in this setting, especially in clinic, as asthma does not cause exertional hypoxemia. One should consider pulmonary vascular causes of exertional dyspnea when symptoms are progressive, unresponsive to treatments, or out of proportion to the clinical data available. PAH is a specific and relatively rare form of pulmonary hypertension. And for a given patient with a right heart failure syndrome on echo or clinical presentation, left heart failure and lung disease will be a far more common cause of pulmonary hypertension. And those patients are not typically treated with pulmonary vasodilators, and they require other therapies. So that's an important distinction to make in practice. Pulmonary hypertension is a syndrome, not a diagnosis, and it's important for a patient to undergo proper pH phenotyping by a right heart catheterization and other ancillary studies, such as chest imaging, exclusion of chronic thromboembolic pulmonary hypertension, other conditions before embarking on a treatment protocol. And you can consider referral to a dedicated pH center to help facilitate this. Finally, chest CT, with or actually without contrast, is an undervalued source of information on the pulmonary vascular bed and the right heart. And it's not always mentioned in the report, so it's worth looking at the images yourself and having a conversation with radiology if you have a high clinical concern for a pulmonary vascular condition. So I'd like to thank you for your time today.